And it's the perfect segue following what Bettina illustrated. This is actually more about policy implementation. So we have the privilege, we're fortunate to have a couple of excellent experts with us who will also help illustrating, and I would suggest that both of you come over, yeah? Will help illustrating how screening programs can be implemented specifically in certain areas, lung cancer and prostate cancer to be precise. The apologies I have to mention relates to the other speakers who were planned to be with us today. Olov and Mattias, who unfortunately are unwell and therefore unable to be with us. That said, perhaps a short word of introduction which tries also to build on what Bettina has illustrated earlier. You certainly know that there has been a recent update of EU recommendations on cancer screening. This was adopted at the end of last year. They are now in the implementation phase. And it's extremely important to consider the implementation phase from different angles. One, and I just pick one for the sake of the discussion that we may have in the next few minutes, in terms of equity of implementation within countries and across countries in Europe. That's just an example. Another dimension which has been raised, and again, we can be more specific on that, is the cost effectiveness of such screening programs. I think it's something which was alluded also in the previous talk. So the work of the European Commission has been guided by a group of experts known as SAPEA, which is one of the many acronyms that the EU loves to inject in our brains. And SAPEA actually stands for the Scientific Advisors for Policy in European academies. So it's scientists, and they have indeed offered an in-depth report, which is available on internet, by the way, that illustrates the reasons why we should be expanding the number of screening programs to enter also, for instance, lung and prostate cancers in particular. And they also offer a series of parameters that, from a political perspective, have been in part diluted by the health ministers of the 27 EU member states. And that's not necessarily something which speaks against the implementation of the programs, but it simply says that there are a number of elements that health ministers from our countries in Europe are taking into account, as it was mentioned, for ethical reasons, clinical reasons, economic reasons, etc. But having made this very short introduction on what is happening, what is the state of play, I think that we want to hear from our friends. Eleanor Wheeler, please. Eleanor, come over on this side, over there. Eleanor is representing the Lung Cancer Policy Network. So thank you very much for being with us. After, we will also have Henrik. You want to jump over here? You prefer to sit? No. Professor Henrik Grönberg, who is from the Karolinska Institute, Senior Consultant and Manager for Prostate Cancer Center, Capio San Göran. Did I pronounce it correctly?
Yes.
That's a miracle.
Yes,
okay?
agree.
In Stockholm, thank you. So the both of you will look at slightly different angles, but perhaps, Ellie, you want to go first and look at the work and the tools which the Lung Cancer Policy Network has launched.
Lovely, thank you very much. Seamless to the slides as well, so this is fantastic. Thank you so much for having me. It's great to be here, and a real pleasure for me actually to kind of be talking about cancer more broadly than lung cancer as well, because my day job is kind of 100% focused on lung cancer and lung cancer policy in particular. And I think one of the things that I'm really looking forward to is the conversations that we're going to have. And, you know, I'm really keen to learn from those of you who have that experience of implementation of breast cancer screening, for example. I just think there's so much that we can take from your experiences to kind of help us as we build what in the EU in particular is quite early in terms of lung cancer screening. So as Eduardo mentioned, I'm from the Lung Cancer Policy Network, and the network itself is fairly new. So it was set up at the end of 2021. And in the last couple of years, it's grown to have 70 members from across the globe. So the focus of the network is global, which, as you can imagine, in terms of policy, is quite difficult. You know, we've got a lot of different health systems, a lot of different kind of contexts that we're taking into consideration as we think about policy for lung cancer. You can see that the network is multi-funder, and actually underneath this box we now have a member from Colombia as of this week, so that's great. We're kind of growing all the time. And really the core aim of the Lung Cancer Policy Network is to ensure that policymakers from around the world make improving survival from lung cancer a key policy priority. And, you know, why lung cancer? Why is this the topic that we as a network are focusing on? So there's a few key reasons. So firstly, the really significant mortality burden from lung cancer. Secondly, the huge economic burden. You know, these are things that the previous speaker spoke about, and we really see them very significantly for lung cancer in the EU, but also across the globe. But also, and I think this is a really key point, and again kind of goes back to the previous speaker's comment around treatment and availability of treatment, we know that at the moment, the vast majority of lung cancers are detected at a late stage, so kind of stage 4. And for those people who are detected at a late stage, the survival rates are very, very low. However, when we see early detection, early diagnosis, we can see survival for, you know, up to 92%. So there's this huge amount of potential to really, really dramatically, you know, decrease mortality and really improve quality of life. It's displayed really nicely in this graphic, which shows the stage shift in diagnosis that can be seen with low-dose CT scans as part of a lung cancer screening program, as compared with no screening. And this is really one of the key focuses that the network has had over the last couple of years, is firstly raising awareness of the really vast evidence base. There's a lot of strong randomized control trials that demonstrate the effectiveness of low-dose CT screening, but also then seeing that turn into some kind of policy action. So the lung cancer kind of piece of the EU recommendations for screening. I feel like this is almost replicating your talk, so I'm not going to go through the criteria, but what I think is really important for us as a network when we were looking at, you know, the recent kind of opportunity to feed into what potentially the recommendations might look like for lung cancer, some of the key points are that, one, you know, lung cancer is clearly a really important public health problem. 2, you can detect it at that early stage via screening. And I think one of the problems of trying to detect lung cancer earlier without screening is that the symptoms are quite vague, quite common across some other health conditions. So things like shortness of breath, cough, especially with COVID, those kind of symptoms, people don't necessarily think lung cancer immediately. And also often by the time that people have got, kind of prolonged symptoms, the lung cancer itself is at a later stage. So as we heard, being able to detect in that early stage before someone even knows that there is a cancer there is, really vital. There is availability of a suitable test in low-dose CT screening. Japan also does lung cancer screening using X-ray, but they're the only country to do so. And all of the randomized control evidence that we have seen really points to LDCT being the absolute gold standard for lung cancer screening. And there is an available treatment, and it's cost effective. It's far more cost effective to treat people at early stage disease than it is at late stage disease. And so the network really came together to pool this evidence, this expertise, and feed that back into the recommendations. And what the output of that was, and I've pulled this directly from the recommendations, is that for lung cancer, we saw the recommendation that countries should explore the feasibility and the effectiveness of screening with use of LDCT, and that particular attention should be given to identifying and targeting high-risk groups, high-risk profiles. So we know that lung cancer, a really significant risk factor is smoking. There's also other factors. For example, air pollution is increasingly being recognised as a risk factor for lung cancer. Things like exposure to asbestos, some of those work-related exposures. And also, really interestingly, not so much in the EU, but in Asia in particular, we see a very strong kind of risk profile in terms of family history that actually outweighs the kind of risk that is seen in smoking. So being able to really understand who that at-risk population is can help us target lung cancer screening. So it's great. We were obviously thrilled to see that lung cancer is now part of the EU screening recommendations. However, there's so much more that we want to do. That's part of the reason that we're here to talk to everyone today. So the good news is that several countries in the EU have already established large-scale screening programs. So I think Poland, the Czech Republic, Croatia as well, and others have made a formal commitment to establish those programs. One of the things that we think is really important is to support the optimization of these programs. So we saw in the EU recommendation text that countries are encouraged to explore the feasibility of screening. And I think it goes back to that point around what is the knock-on, what is the impact kind of further downstream, what does it mean for the care pathways for lung cancer, what does it mean for capacity and workforce requirements if we change the shift or shift the stage of detection to early stage, and we see an increase in stage 1 and stage 2 lung cancers, what does that mean for then the downstream effects in terms of what treatment is provided? Croatia, I think, did some really nice modelling work looking at the predicted increase in terms of surgery requirements. And then obviously we also need to look, what does that mean further down if there is potentially less kind of bypassing of the care pathway and moving to kind of end of life and palliative care where treatment is maybe not so effective at those late stages. So there's a lot to think about in terms of what the implementation of screening means for the health system more broadly. And I think one of the things that I would say is very particular to lung cancer, but I'm also very happy to be corrected on that, is that we have experienced a real stigma from policymakers, but also from the general population in terms of things like people feeling that lung cancer is a self-inflicted disease, that there's sometimes less support for screening, because of this association with smoking. And there's also a lot of misconception around lung cancer, again, in the kind of policymaker environment, but also more broadly in terms of misconceptions that there aren't treatments available. So there's a lot that we need to unpack really about that and help educate and inform people, not just about screening, but also, the benefits and potential that treatment holds. So what the network is doing, particularly to support this, is trying to pool its collective expertise and to make freely available very practical evidence-based resources to support locations to explore implementation and really to learn from each other as well. So, the US implemented screening for lung cancer, I think, over a decade ago. That's fantastic. They've come across real challenges in terms of securing uptake. And I think there's a lot of learning there about how to reach out to underserved communities, how to make screening accessible, that we can take into the EU and preemptively address some of those challenges as we have the opportunity to design these screening programs from scratch. So one of the things that the network has done is put together a global map of LDCT screening. The database is, completely open access, freely available. It captures the kind of policy level information about a location. Do they have a national cancer control plan? Do they talk about specific cancers in that control plan? And also delves down into the detail in terms of, is there an implementation pilot going on? Is there a national program? What is the eligibility criteria? What are the protocols? So again, those that are looking at designing, implementing, and optimizing screening programs can directly take that information and learn from it and utilize it. We also published Lung Cancer Screening Learning from Implementation report. There's a real theme that goes down our outputs. And this, again, really draws out some of the key lessons, again, on a global level from implementation that really aim to address some of the challenges that people might face and show some of the practical solutions and kind of ways that people have optimized screening to make it as effective as possible. And then earlier this year, we launched an implementation framework for LDCT screening, and that has an entire online toolkit of resources and templates, and also a series of policy briefs that really aim to support locations to draw out the key policy requirements around implementation. So the framework can be applied to assess health system readiness of a location to implement LDCT screening, and by doing that, enable a location to go and engage with policymakers at a more nuanced level than kind of having the ask be, we would like to see screening for lung cancer, but taking it that kind of step more into the detail to say, we'd like to see screening for lung cancer, and here are the three biggest challenges, whether that be about infrastructure or workforce requirements, to really enable that detailed level of conversation to take place. So from the perspective of lung cancer in Europe, I think it's fair to say that it's early days, but the momentum is really starting to accelerate now. And we're seeing that across the rest of the globe as well. There's fantastic screening implementation going on in Taiwan that has already seen a really significant stage shift, and the majority of the cancers that they're detecting in those programs are stage 1, which is, kind of fantastic news and fills me with optimism for what lung cancer screening could deliver across the whole of the EU. I'm going to wrap up just by sharing a QR code. If you did want to go and look at any of those resources, please do feel welcome, and hand over to the next speaker.
Thank you very much indeed. There is, as you said, there is a lot of work to do, but these are very concrete tools that can facilitate the implementation or the understanding of how to implement. Now, obviously, I encourage everyone to think about specific questions you may want to ask Ellie afterwards. But in the meantime, let me welcome again Henrik. And from your perspective, from prostate cancer, probably we can have an additional angle.
So can I have my slides, please? So I'm going to, okay, let's see. So I'm going to talk about prostate cancer. And we are in a little bit different situation. We are already in the situation here in Stockholm or Sweden that we use prostate cancer testing already in the public, completely unorganized. So I'm going to talk about how to integrate a new prostate cancer test in an optimal prostate cancer screening program. And I'm talking both as a researcher and as a clinician. So this is the situation in Europe today. Prostate cancer is definitely one of the most common cancers in Europe, and is actually causing almost 70,000 deaths. So it's not I would say, between 20 and 25% of the men that are diagnosed with prostate cancer today are actually dying in prostate cancer. And 1 in 11 will actually be diagnosed with prostate cancer. So this is a serious medical problem. The one thing I think is very important to stress here, we're talking about screening, testing. Most patients have no symptoms before it's too late when it comes to prostate cancer. There's actually a misconception that urinary symptom, which is very common in the elderly men, is a symptom of prostate cancer, but it's actually inversely correlated to prostate cancer. So if you get pain, it's too late. So this is definitely a disease we need to find before symptoms. So how do we do that? So I think very, very roughly, you do a blood test, you do imaging, today with an MRI, you do biopsy, pathology, and then treatment decision. So this is the pathway that all men that are diagnosed with prostate cancer will go through. We've had PSA, prostate-specific antigen, as the biomarker that's been used in Europe and I mean all over the world for 30, 40 years. But it has well-known limitations. We know when at low sensitivity, it actually misses somewhere between 30 and 50% of all aggressive cancers. And low specificity, particularly, I mean, 70 to 80% of men with an increased PSA above 3, which is the level that we use in Sweden, are false positive. So it is one of the best biomarkers, blood-based biomarkers in cancer, but it is really, really poor. So how do we go from there? My research group, we said, could we do something better than that? So that's why we, I think 15 years ago, started a large research program. We looked at all different biomarkers that were associated with prostate cancer. We combined, in the Stockholm 3 test, 5 protein biomarkers, about 60 genetic SNPs that are associated with genetic susceptibility, and then clinical information into one algorithm to try to say, what is the risk of having clinical significant prostate cancer today? And then it's an easy interpret result from this algorithm that is quite complex, but the result is simple. So what have we done? Well, during these years, we've been publishing over 25 publications about Stockholm 3. And we have had large research programs, and over 75,000 men have been included in clinical studies. Now we're going to only talk about one of the last ones that we published. And it's used in routine clinical care, and over 70,000 men have actually used it so far in Europe. So I'm going to talk about one of the last studies that we did. We're actually combining the Stockholm 3 test with an MRI. And MRI is definitely part of the diagnostic chain of prostate cancer today, no doubt. So what we did here in Stockholm in the years of 2018 to 20, we invited 12,700 men were participating in the study. And they draw blood. And we used both PSA and Stockholm 3. If it was increased, they were randomized to traditional biopsies or biopsies based on MRI. And we published 2 main publications in New England Journal of Medicine and Lancet Oncology. We also published health economic evaluation on this. And I'm only going to... These are the different comparisons you can do, and just sake of time, I'm just going to look at the last one. And also the last oncology paper was in 2022 by EAU, said that this was the most important prostate cancer paper published in 2021. So I'm just going to say one comparison. PSA has been used in screening programs, or it's not been used in population-based screening programs, but it's been used a lot. So what happened if you combined Stockholm 3 and MRI compared to PSA? Well, you overcome a lot of the problems with overdiagnosis and overtreatment, because we can take away about half of the biopsies that you need to do if you only do PSA. You will find almost 70% less of the Gleason 6, the small indolent tumors that you don't want to find, that actually causes a lot of overdiagnosis and overtreatment. But you also find more Gleason 7, which are the clinical significant ones. So I think this paper really shows that if you combine a good blood test and MRI, you can get very far in the diagnostic chain. So I'm going to talk about a couple of minutes about what we've done here at Capio St. Göran Hospital, because in 2017 I was going to this hospital and setting up a prostate cancer center. And in 2022 we were responsible for about 40 to 45% of all prostate cancer diagnosis and care in Stockholm. And we initiated over 900 new treatments last year. So what we said here, how are we going to use these kind of new diagnostic tools in a very efficient way? We said that we need to task shift from doctors to assistant nurses. We use the homepage for online testing. We draw blood as any of the test centers, so the man himself can actually order the prostate cancer test online. After all, of course, a lot of information. And 85% of the men have no increased risk. They just get a letter saying, please come back in 2 or 6 years. And then we directly, of course, go to MRI, an ultra-short program. And then for the first time, when the patient is going to have a biopsy, that's the first time that he sees a doctor. And then you go, of course, to conference and treatment. And this has been a very effective way of actually running prostate cancer diagnostic and treatment in the center. And we published this year in the Läkartiden, which is medical association journal, the results for the first 5 years. And we have been testing over 12,000 men in this diagnostic chain. And I'm just going to tell you a little bit about 2 things I think is important. I'm not going to talk about the medical or the medical results, but I'm going to talk about clinical resources. If you test with PSA in GP offices and then go to open care urologist, compared to the Capio model where you use Stockholm 3 assistant nurses, you can see that you do half as many MRIs, you do 90% less doctor's visits, and 40% less biopsies. So it's actually very resource. I think this is important. If you're going to implement something big and common, you need to use resources wisely. But also shorter lead times. I think this is very important for patients, that you cannot wait. In Sweden, we have too long waiting times for initiating treatment. But also cost comparing current national guidelines with the Capio model. We can show that if you use Stockholm 3 MRI with assistant nurses, you can cut between 25 and 30% of the cost compared to the national guidelines today. And I think this has implications. And I think that if I'm going to wrap this up, it's a short talk. I would say that in prostate cancer today, we have the tools actually to implement screening programs. And screening programs can be, of course, based on individual basis that we have currently, or population-based screening programs. In Sweden today, we have several pilot projects we call organized prostate cancer testing. That's ongoing in, I think, 15 or 16 parts of Sweden. Looking at different algorithms, both with PSA, Stockholm 3, and MRI. I think definitely with the data we have today that the benefit outweighs harms. And I think we have the tools to make modern screening / testing programs today. And I think here is really the problem for us. We have a different angle compared to lung cancer because you don't have the low dose CT. It's not available outside the screening programs. But here in Sweden and a lot of the countries, we do PSA testing a lot. And just as getting some kind of framework to this, just in Stockholm with 2.5 or 2.3 million people, we do about 140,000 PSA tests per year. And 70% of all men aged 50 to 70 have done at least one PSA test the last 5 years. So there is an unorganized, widespread screening, and we have to put it into much more organized programs than we have done. And I think if we do that, I don't have that slide because I cut it off, the mortality of prostate cancer will decrease. And I have this fantastic slide comparing breast cancer mortality over the last 25 years in Sweden compared to prostate cancer. And prostate cancer started at 40, and 25 years later, it's at 20 per 100,000. And breast cancer have gone from 30 to 20. And last year, prostate cancer mortality was lower than breast cancer mortality, age-adjusted for the first time. And I think that if we use these wisely, we can definitely decrease mortality even further for prostate cancer. So, as I said, just do it. Thank you.
Excellent. Thank you very much, Henrik. Very clear, straightforward. Let me see if there are any questions. We've got a few minutes left before the lunch break, I believe. Any questions? Bettina, please.
If I may, a remark. Thank you to you both. The prostate case for me, prostate-specific antigen, is a proof that unorganized screening on individual basis can be dangerous. I have seen a lot of completely panicked men due to whatever PSA tests, and I think you're completely right. Get it organized, but again, you're working in a country where you have data. I wanted once to ask how many PSA tests have been done in Geneva or Switzerland. No access to the data, but I know it must be like here in Stockholm. So thank you again for having the data. And thank you for you. Lung cancer is stigmatized in a wrong way. You just should stop smoking. That's not enough. I mean, that's very bad. We know how many other cancers in lung do come for young women, non-smoker, adeno ones. So you're struggling with something else in addition.
Any other questions or comments? One point which I almost rhetorically would like to put again on the table to your attention is something which I had referred to, and it's part of the so-called SAPEA report. Remember, the one which has been guiding the decisions at European level on the recommendations, and it's specifically about cost effectiveness. The SAPEA report highlights that cost effectiveness is an essential consideration when introducing screening programs. So now, from both of your analysis and illustrations, there seems to be a clear cost-effective result, let's say, outcome through the appropriate implementation of screening programs, respectively for lung and prostate. Can you comment on that? Because really it's something which several governments are struggling with.
I think, I think there's been published several reports now when it comes to health economic elevation of prostate cancer screening programs. And there is no doubt that there are cost effectiveness if you use the new tools. PSA alone is not cost effectiveness. But if you use PSA or MRI or Stockholm 3 or MRI, it is cost effectiveness. So I think I don't think that is an issue anymore. I think it really is more about implementation. How do you do this? Do you have the resources to take care of patients afterwards? That's in my view.
Yeah, I think, agree. The equally for lung have been multiple models and cost effectiveness analysis that show that screening would be cost effective, particularly in terms of the way that lung cancer screening is targeted. So all of the programs that have already been implemented, the eligibility criteria is not the full population, it's the population who are deemed to be high risk. And I think one of the things that is a particular strength that we've seen in LDCT screening programs already implemented, both in the EU but in other locations around the globe, is that they flex that eligibility criteria to specifically capture the highest, at-risk population at that time, and can then also amend that as new evidence comes out. As I was saying, this kind of increased understanding of other risk factors. So I think, that in particular is one of the strengths and cost effectiveness for lung cancer screening. So you asked how they find the high-risk groups. Yeah. So again, it varies a little bit depending on how the screening program is set up. But for example, in the UK, one of the key criteria that they are using is basically smoking history, so amount that someone has smoked, age, and the UK has got a registry and database that can be used to identify those people. Other locations don't necessarily have that information and also have different criteria. So I think it's one of the, kind of varies on a location by location basis. In the EU, there is more infrastructure and more data available. And in some of the other locations, that is more of a hurdle. But I think, engagement of GPs has been really key in the screening programs that have been implemented to inform who should be referred to screening. If they understand which of their patients meet some of the criteria for being high risk, they can refer directly into screening programs. Also, that kind of public awareness piece that I talked about. So if a screening program is set up, for example, I think in China there was one set up specifically to target a mining community who have got very increased risk of lung cancer. That's a kind of public awareness piece, as well as that kind of engagement with that particular target group.
Which, in theory, should also help or facilitate the access to screening programs of underserved populations, because if the target is set in a way which also is inclusive of the entire population, I guess this can reduce inequalities in access to programs and, as a consequence, access to care. Is that a fair comment as well?
I think that's a very fair comment, and I think there's consideration of inequities and access along the whole spectrum in terms of who is the at-risk population. Often those populations are from underserved communities, but also things like, and I don't know how this differs maybe for prostate, but for people to physically go and have a scan, requires there to be an LDCT scanner available. And so some of the considerations that we've seen in places like Australia, for example, that have very rural populations, will use mobile CTs to take a screening program to a community and there kind of address some of those barriers in terms of geographical spread and access in those ways as well.
So I think you'd be surprised how uneven the prostate cancer care, even in Sweden, is. So I think this, to organize everything in a more structured way will actually take away a lot of the inequality that we see. And I would say it's not only inequality from, which area you live in, it's social inequality, but it also is really inequality to which doctor you see. You'd be amazed by the heterogeneity between doctors, how they look at prostate cancer, how they treat prostate cancer. And this is, of course, something we need to work within the medical community. But the more structural, like we had put up on in St. Göran, the better the care it will get. So I think this is something that I'm thinking about more AI-based decision tools. This is something that I see as the future, that we actually, it's difficult for doctors today to understand all the different new things that comes into play when you are supposed to treat a patient. But if you have AI-based tools, decision tools that are available for more clinicians, that is going to make the care much more even than we have today. So I will definitely see that within 2 to 3 years we will have that.
Well, on these notes, perhaps we can close unless there are burning questions. And the very positive messages that both of you have shared with us today is that there is a clear fine-tuning of the programs and the tools which can be implemented for cancer screening, certainly in your respective cases, lung, prostate, and that these programs, if conceived in the appropriate manner and therefore implemented appropriately, they not only can be cost-effective, but they can certainly have a significant impact on, positive impact on outcomes, on health outcomes. So on these notes, I think that we as a community should continue to pursue the appropriate implementation of screening programs and join forces also to avoid inequalities which do exist. And again, that's part of the reports which are being updated as we speak on equity of implementation of cancer interventions at large within Europe and even within single countries in Europe. I think we should continue to promote a fair implementation. Thank you both very, very much, and thank you all for participating.
Thank you so much. And actually, it's not lunch yet, but we're a bit behind in schedule, so we will take it a bit shorter this next session. And I will leave the mic to Björn and to Eskil to start with.
Please stay. Oh, okay. So, in interest of time, and I know you're all hungry, we will shorten this session a bit. But I would like to introduce you to this topic, the European Code of Practice in Cancer Care, and we're going to listen to Eskil Dexell. He's the chairman of the Swedish Brain Tumor Association and researcher at Karolinska Institute. And also, most of you know Pernilla already, you know, founder of Fokus Patient, member of the EU Cancer Mission Board from Sweden and so on. So, I would like to give the first 5 minutes to you, Eskil, to give your view on the topic, and then we will have a short discussion, and also we would like to include you all in the audience. So whenever he's ready, please raise your hand and you will have the microphone and we can start the discussion. So please.
So thank you. Do you hear me? Yes. I was a little bit amazed to be here today. I'm the vice president of the Swedish Brain Tumor Association, and as you saw on the previous slides, there is no prevention working for brain tumors. And as you also, with the topic goes forward, we also spoke about early detection of disease. And to be honest, if I received a brain tumor myself, I rather would like an inoperable glioblastoma in a late stage. Because we see for brain tumor patients, when they get the brain tumor as a child for pediatric care, or for when they get it in the early stage of their lives, I won't say it's not, it's sometimes quite unworthy life to live as the effect of the disease and the treatments. So I think I was a little bit surprised to be here, but we also, as a brain tumor association, we tend also to work a lot in this European Code of Conduct and try to a little bit hang on and to see what can we as a community do. But I also learned it was this year, I learned from Hans Rosling's son Ola, and it was a nice insight that if we erase cancer, we take away that disease in Sweden and Scandinavia, then we will prolong life for the Swedish citizens by 3.5 years. So even if we take away cancer, even if we don't get it, we will still die. And we will still have to handling that. And that is also a really humble opinion to keep in mind, that even if we all do this prevention and we all do this all with early detections, we still have to face death. And I think Lancet did a fantastic commission report in saying bringing death back into life. And about also to speak about the things in the code, that also the policies that don't medicalize life. Don't make our lives so afraid of death and dying, because we're pushing a lot. And we have to be humble that, especially for Brain Tumor Association, we are really humble that we will get alive and we will die. And also what Olov Rusling said, that if we focus on delaying aging, if we can delay aging, the time when we get our first disease, we will probably increase median overall survival with 10 years. So I think also if we look at the code of conduct of cancer, we need to learn from other areas. We need to be really humble to see what can we learn from other disease areas or other things. Because even in the brain tumor field, we believe that all the advice that comes from the code of conduct, with not smoking and be healthy and eat well, we can actually benefit from it. Not in a prolonged life, but perhaps in a more quality of life. So we have to be really humble, I think, in a way that if we look for different codes and different policy documents, and cancer community has to be really humble that we can learn from others and sometimes help from others. And I think that's, we spoke a lot about that because brain tumor is a neuro-oncology disease. So we collaborate a lot with people with neuro diseases and people with psychiatric diseases. And to be humble, it's the mental world state today, and we have to be really humble that people in Sweden, we're not feeling anyway good. The young people and people of Sweden are actually, the mental health is really, really declining. And another thing in Sweden, we are the loneliest people in Europe. We are the most people in Europe that doesn't have anyone close to that comes to when we seek help. We don't have any families. We don't have the strong community that you have in Romania. I was really jealous. So we have to be really humble that when we look at all these policy documents, we need to put it down to our context and to speak up with the community, the ones that are living with the communities, and to say, okay, how do we handling problems or together? And a little bit what I missed in the code of conduct, what we need to speak a little bit more trust. How do we create trust together? Yeah, I believe that one way of creating trust is to solving or handling different issues together. So, and when I was invited here by Pernilla, we also say we have put a lot of time in the brain tumor community to put on, this is the patient rights. We have the right to access care. We have the right to get a second opinion. We have different rights on that. But when we see now, when we come with all these demands, we also need to speak about what is our obligations. What is our obligations as citizens when it comes to health? Do we have any obligations? We need to speak about that. Do we need to be honest with healthcare providers? Do we need to tell the truth to the doctors? Well, if we put that in a context, that will be very complicated. Do we need to share our biomaterial? So when we speak about policy documents, we speak about cancer, and we speak about patients' rights, we also need to get that question up and running, especially in sessions like this, because it's about policy sessions, and we need to be really humble that those policy documents and what is in them is conducted in collaborations with the citizens. I'm a member at Biobank, Sweden. It's a large corporation handling biobank issues. And when we see in Europe, there is such a large problem in how to handling samples for biobanks. So that the states are failing, the universities are failing, the industry are failing. So we now have gave the community of citizens, how can you help us to solve the problems with conduct the biobanks problems that we're facing in Europe. So sometimes we need to put back the questions to the society in order to help us to develop them. So that was my little start of speaks, and I would like to...
Please, Pernilla. Thank you, Eskil. Give him an applause. Thanks. First of all, before I let you guys in, I would like to have a comment from you on what Eskil is saying.
Well, I think that we are talking about two codes really, and you know, the codes or the patient right for cancer patients. That's one, and it stipulates about, you know, access to care and so on. But we also have this one that we have heard about from Elisabeth and other speakers today, the European Code Against Cancer, where you can really see the citizens' responsibility also for their own health care. And especially, of course, for the risk of cancer, that you need to take care of yourself and to avoid and to prevent cancer. So there are two different codes, and we need them both, I think.
Any comment on that?
Yeah, we need to develop the codes. The codes are not static documents. It's really needed to be developed all the time in the society, because the society is a mirror on how we act. And that's what I said, that the trust is so important. How do we build trust in a society towards health? I was on a session earlier this day, and I heard it's a lot about early detection in the primary care. But I work with brain tumor patients. Most of the patient doesn't even come to primary care. They don't. We can have so much access. We can have a lot of access, but they don't have the capacity to go from home to care. We have a lot of people with cognitive dysfunction in collaboration with cancer. So we need really to be humble and to say, how do we handling challenges that the society has, and put those into policy documents and push it forward.
Any comments or questions from the audience? Anyone? Yes, please.
First of all, thank you a lot for your thoughts, and I think very important. The danger of medicalizing life is always there, and it's part of the biomedical complex. It always has been. Even in the 19th century, doctors invented diseases that then disappeared because the hype was over. I talk about hysteria.
Exactly.
Was very big issue. Very important men became very important professors with whole hospitals for hysteria, which only goes to women, which helps a lot. But we have these examples throughout history that we medicalize things. And when we medicalize them, we have to think what and why. Do we put this or this part of society as a patient? Because putting them into a hospital or into is a certain view on society. So I think your point is well taken. What you say is we have to look at our societies, first of all, to understand what we do with health and disease. And I think brain tumor in this sense also illustrates very well what I said. They are so different, the diseases, that some of them come like brain tumor. They are there and you didn't know, and your environment didn't know, and suddenly you're a completely different person. And you have to accept it. And I think that you're very, very right with the word humbleness. We are not the masters of the universe. We are suddenly very small little individuals. And if it comes to prolonging life or to do, we have to really look at what is it, when is it, where is it important. That's why I said all screening, all detection needs a transparent policy and explain why here we do it, why we think it is worthwhile compared to, you know, the normal course of life. But thank you for putting our attention to this important view that we have to have on society and on the mental health, World Mental Health Day today. Thank you.
And I also would like to respond that it's I'm writing also in the national guidelines for brain tumors on them. And brain tumor is a fatal disease for the most. And it wasn't a sentence in how to plan a good death in the national guidelines until the patients and the society would like to have that. So I think that's what I say, there's a lot of trust and collaboration also to build the policies and to handling different, not solving problems, we probably not will solve, but handling different problems that are existing in society using different type of policies, but also be a little bit critical on the policies, saying, okay, this will not fit all. We need to be humble on that. And if you look for early detection, it's really also a large industry-driven thing. We have to be really aware of that.
But I also think that, you know, at each level or in each area of life and society, we need to have documents, guidelines, and so on, to have something to lean on. But with that said, because yesterday we were also discussing, can it be person-centered really if we have all these standardized, you know, care processes and so on? Can it really be person-centered? And that's also a question about when you're creating all these codes and so on. But we need to have some kind of guidelines in society to really have something also to you know, to complain. You know, we like to complain as human beings, don't we? and we like to see that, okay, we really cannot, you know, measure everything in life for yourself, but at least you can see, okay, you can be quite pleased, you know, when you see the guidelines about alcohol or tobacco or food or something like that, because, okay, well, I ate my carrots, I don't smoke, I don't drink so much, or whatever it is. You can feel quite pleased, you know, also. So I think we need it because we need also something to you know, to have as a vision, something that we really run forward to and have a goal to reach in some way.
And I do agree on that. I just must tell you a small, we're conducting a systematic review on how to capture experience from informal caregivers, but also experience from bereaved in cancer, and use this data for quality improvement in care. How many articles did you know, if you think we find? None. So we have a lot of bereaved people close to cancer in Europe, but we didn't even bother to ask them and use that information for quality improvement.
Often you should always end on a high note. We don't do that now. But I think we need to end this session also in the interest of time and hunger. So thank you very much, Eskil. Thanks for the comment, Pernilla. We all will go to lunch now, and we'll be back here latest 13:15 for the theme of treatments. So warm applause. Thank you.
Thank you.
Thank you so much.